5, 4, 3, 2.
Good afternoon, my friends. The doctor is in the house. Welcome back to another episode of To Your Health with Dr. G. My name is Dr. Mark Gomez. I'm a board-certified internal medicine physician practicing at Edward Hospital in Naperville, Illinois. So welcome back to our return listeners and welcome to our new listeners. Today we're going to have a great show. We're going to be talking about the opioid epidemic. And the panel that I have assembled today is what we call #fierce. So thanks again for joining us. For those that are new to the program, what I do each week is I invite some of my experts in the field of whatever topic we're talking about, and we just have a conversation. We try to make some points available for people to learn and then to apply in their daily lives, for them to feel empowered in their medical decision making, and to engage in more dialogue with their physicians. So today, we're going to talk about the opioid epidemic. I want to do a quick shout out to our gold level sponsor, Gateway Spine and Pain Physicians. You can find them at www.gatewaypain.com. Let me hit you guys with a quick disclaimer as usual. The content of To Your Health with Dr. G is for informational and entertainment purposes only, and that the content is not intended to be a substitute for professional medical advice, diagnosis, and or treatment. For further details, you can visit www.toyourhealthwithdrg.com/disclaimer. Excellent. So again, I want to, before we go in and welcome our committee and our expert panels today, let me just tell you a little bit more about what we're dealing with. So today we're going to be breaking down the opioid crisis, and in particular, this episode is entitled Addiction, the Battle Within, Part 1, the Opioid Crisis. So how I start the show out is we talk about, in medicine, we talk about something called the chief complaint. So when somebody comes in and sees us, usually they come for a reason. And so the chief complaint of the hour is really about what is going on with this epidemic and what can we do about it. So I want to give you guys a couple quick talking points and just to think about this, and then we're going to introduce our guests. So the opioid epidemic is something that's happening and it's real. A couple quick points. Prescription opioids are some of the major driving factors of the current opioid epidemic, including prescription drugs that make it onto the black market. Also, illicit opioids are driving the current epidemic as well, including potent, illicitly manufactured synthetic opioids such as fentanyl. Some of the trends that we're dealing with, because this issue can really affect any of us. Even if we go to get a simple surgical procedure, we can potentially be prescribed opioids. So let me give you a couple quick trends. Physicians in the U.S. prescribe 3 times the amount of opioids currently as when compared to 1999. Physicians in the U.S. prescribe 3 times the amount of what physicians in Europe prescribe for similar conditions. It's also been shown in Japan as well. Overdose deaths involving black market opioids have surpassed deaths involving prescription opioids. Opioids kill a larger proportion of recipients than any other medication class. And nationwide, 91 Americans a day die from opioid overdoses. So we're going to let that kind of information sit. We'll talk about some of the state of Illinois where we all reside, to those that are listening out there in the worldwide internet. But the state of Illinois has some interesting data as well, too. So again, my name is Dr. G. We're going to talk about this broad topic, but we want to make it understandable and relatable and have some good take-home points at the end of the day. So what I want to do is I want to introduce my esteemed panel of guests that are experts in their own fields on how to give us some guidance onto how we can best address this epidemic. So without further ado, my first guest sitting to my right is Dr. John Hong. And I've known Dr. Hong for maybe about 7, 8, 9 years, something like that. But we met, actually I think we met in probably 2007 when you started your practice. So more than a decade now. But Dr. Hong is a double board certified physician. He's in pain management and anesthesiology. He's the founder and president of Gateway Spine and Pain Physicians. You can visit them again at www.gatewaypain.com. So Welcome to the show, Dr. Hong, and why don't we just start off by saying, give us a few opening remarks on how do you see opioids in your practice?
Well, thanks for having me on the show, Dr. G. It's a true pleasure to be part of this. Yeah, I've been in practice of treating pain for the past 10 years in private practice in both the acute and chronic inpatient and outpatient settings. And I've really been at the front line of treating pain and as such also utilizing opioids, looking for alternative treatments other than opioids, trying to minimize opioids as we all know that they do have risks. Over the past 10 years, it's been an interesting evolution that I've had the opportunity to witness where initially there was almost an expectation for physicians to prescribe opioids for moderate to severe pain. And the current state that we're in now, it's almost frowned upon. And the pendulum has certainly swung the other direction. My concern, and I'm sure we'll touch on this later in the show too, is that there are legitimate chronic pain sufferers that depend on opioids. And these individuals sometimes are bearing an unfair brunt of this backlash against opioids. So it's a complex problem, no doubt. There's a lot of factors that weigh into the opioid epidemic. But it's certainly a worthy topic of discussion given how serious this opioid epidemic has become.
Thank you, Dr. Hong. And when I first thought of this show to talk about, he was one of the first people that I thought about because I've known Dr. Hong for a long time, and really as a physician, this is an issue that you deal with on a day-to-day basis. So, and again, the panel that we have today, they've got their own unique scope on how they see the epidemic, but they can offer some tangible approaches on how we can best manage this condition and this epidemic. My second guest, her and I go way back to our days at Loyola Street School of Medicine. Giving a quick shout out to Loyola. Dr. Kate Johnson, she's an assistant professor. She's actually got multiple board certifications. I love it. She's board certified in adult and child adolescent psychiatry. She's also board certified in integrative and holistic medicine. She's an assistant professor at Loyola University Medical Center. You can find her at www.lumc.edu. This is our first time connected in a long time since we graduated from Loyola together in 2004. So when I put this panel together, I go, I know somebody that's out there. And so I thought of Dr. Johnson. So Dr. Johnson, welcome to the show. And why don't you give us a quick kind of remarks on how you may see the epidemic from within your scope of your practice?
Absolutely, absolutely. I'm so glad you thought of me because it's so great to be here and catch up a little bit too. So I'm a psychiatrist. I don't treat pain directly, and I personally don't prescribe methadone or Suboxone or any of the other kind of direct opiate addiction treatments. But I certainly deal with a lot of this. There's a significant component of pain for a lot of people with depression and anxiety. There's certainly opiates and substance abuse in general can contribute to mental health symptoms as well. There's a significant amount of overlap with all of this. And often you can't treat one without really considering the other. So, this is something we kind of come across on a day-to-day basis.
Excellent. Thank you, Dr. Johnson. And really, what we're going to be trying to talk about is what can we do? And as Dr. Johnson mentions, it's a complex issue. There's so many factors at play when we're dealing with properly treating our patients and taking care of our loved ones. And the reality is that this issue can touch just about anybody.
Absolutely.
My next guest is Dr. Aaron Weiner, and Dr. Weiner and I, we actually participated in a committee together at Edward Hospital. We met almost 2 years ago, and we met on a subcommittee to talk about how can we develop and integrate strategies at the hospital system and implement them system-wide to deal with this growing epidemic. So Dr. Weiner is the Director of Addiction Services at Linden Oaks Behavioral Health. You can find him at www.eehealth.org. Dr. Weiner, thanks for coming on to the show. And why don't you tell us a little bit about your background and maybe a few open remarks about this topic that we're trying to talk about today.
Yeah, absolutely. So as the Director of Addiction Services at Linden Oaks and Edward Helmhurst Health, I have a unique position where I get to see how medical systems interact with this epidemic, but then I also oversee the functioning of outpatient clinics as well as a detox unit for addiction. And so I get to see the end result if this gets out of control, turns into chemical dependency, and someone really needs some help. And there's been a lot of work that we've done, that you and I have done together. I think our health system's making fantastic strides, but the biggest thing for me, and where I think I invest most of my energy right now, is really trying to help health systems and physicians understand how best to interact with opioids in their practice and in the systems that surround their practice. Because when you look at the history of this, healthcare and prescribing opioids really lies at the heart of where we are right now. As the prescribing rate went up, as you mentioned in the opening of the show, so has all the negative consequences. And so we really need to take a hard look at how we're doing things.
Excellent. Thank you for coming on to the show today, Aaron. Thank you. And my last guest is Mila Tsagalis, and she and I connected actually through the mutual contact at the DuPage County Health Department, where I used to help co-sponsor some programs a number of years ago, and just getting engaged in primary prevention and community health and empowering other stakeholders as we tackle a whole variety of health topics. But I wanted to have a nice and unique perspective for what's going on at the public health level regarding this epidemic. So Mila Tsagalis, she's the director of community initiatives at DuPage County Health Department. You can find them at www.dupagehealth.org. Mila, thank you for coming on to this show. Welcome, and why don't you give us just a few kind of commentary. First of all, why don't you tell us a little bit about your background, but then give us a little commentary on just how you see within the scope of what you do from a primary prevention and community engagement perspective.
Thank you, Dr. Gomez. It's really nice to be here with you. My background is in public health, so much of what I do is to work within DuPage County and with some partners to bring awareness to public health issues. And since 2014, the health department has been actively engaged with law enforcement and partners to start the DuPage Narcan program. And I have the pleasure of directing that program. We've seen great success with that program, and more recently now, the health department, with partners, has been able to focus now on connecting people beyond Narcan to treatment. And one of the things from thinking about public health, in DuPage County, we're fortunate that the county has recently been ranked as the healthiest community and the healthiest county in Illinois, which is fantastic. But that's because we have such strong healthcare partners, Linden Oaks and Elmhurst Hospital among them. But we do see the opioid issues and drug overdose deaths as being a threat to that, and a primary concern for us.
Excellent, and thank you for coming out to the program. So here we have it, everybody. We've got just a great group of experts that are from a variety and a different background on how they see things on a day-to-day basis. And really, this problem is real. To give you kind of an example, I certainly see patients on the front end as a primary care physician. We see patients that come in all the time with pain, a lot of times legitimate, but we don't want to stigmatize those patients that may have failed various interventions and then say, oh my goodness, now we have to give a drug that may come with its own stigma as well too. One of the big things that we talk about in this country, again, how do you best tackle this problem? And again, we're talking about a very broad topic today, and there may be different strategies from how do you tackle it from the supply end versus on the user end. And one of the things that I kind of found interesting that in my research prepared for the show, I found out that actually our Drug Enforcement Agency in 2016, a law was passed nationwide that made it a little bit harder for the DEA to seize any threat of large quantities of pain medicine. It's actually known as the Ensuring Patient Access and Effective Drug Enforcement Act of 2016. And prior to that act being implemented, the DEA had a little more latitude on seizing drugs, opioids, prescription opioids that may be diverted onto the black market. And actually, after this law was passed, it made it a little bit harder. So there's actually a higher legal bar for the DEA to suspend orders. And we're looking at things on how pain clinics may order medicines, or how physicians may order it, or pharmacies may order it. And it's interesting, when the law was passed, there was actually a lot of lobbying going on to get this law passed by the pharmaceutical industry as well as distributors. So what we want to do, of course, is we're going to talk a little about some of the ways how we can effectively educate not only physicians, but also health systems and patients, but also what can we do for those on the back end that may have been receiving medicines for a long time, and then they may not have some of the access or the equity to some of the resources to help with the addiction. So what I want to do, actually, I want to break this down a little bit, and I actually wrote this down, so I did my homework for everybody out there in the listening world, because I think this is an important concept to speak volumes about the power of opioids. And I think that's really going to hit home for people, but it's always, and I try to do this the best I can. I get asked a lot in my practice, when you prescribe a medicine, well, how does it work in the body? And we get that a lot as clinicians on how does it work. And one of the key things that I personally think that a good clinician has the ability to communicate effectively to patients that may be receiving something. So I actually wrote this down because I don't want to mess up my words, and I want this to be as true as possible for people that are listening. So we got the brain. We actually make endogenous opioids, meaning that it's made in the body. And those opioids attach to receptors within the brain itself. And so once those opioids are attached, they send signals to the brain, and that's called the opioid effect. Now we're still talking about natural stuff. We're not getting into the prescription or other synthetic type of opioids in this, and we'll get there in a second. But this natural opioid effect, what does it do? It blocks pain, it slows breathing, and it produces a calming and antidepressant effect. However, the body can't produce enough natural opioids to stop severe pain or chronic pain, nor can it produce enough to cause an overdose. So what happens when we talk about like prescription opioids or anything synthetically made? The reality is that opioids, when they are consumed synthetically or legally prescribed, opioids actually activate brain receptors because of a similar chemical structure. And it's this similarity that actually fools those receptors and allows the drugs to lock onto and activate nerve cells. So then what happens? But then as it locks on and activates nerve cells, you actually can get an abnormal message that's then transmitted into the network. And opioids target specifically the brain's reward system. And that's something that we, and certainly as a clinician, I know Dr. Hong does it as a clinician as well too, and even most of our panel as they interact with patients on a daily basis. But the brain's reward system is called dopamine. And what does dopamine do? It regulates movement, emotion, cognition, motivation, and feelings of pleasure. But this overstimulation that can happen rewards our natural behaviors and produces euphoric effects. And these are sought by people who misuse drugs and teaches them to repeat the behavior. Our brains are wired to ensure that we will repeat life-sustaining activities and associate them with pleasure or reward. Whenever the reward circuit is activated, the brain remembers this. And that's the important thing. The brain remembers that, and it teaches us to repeat again and again, and sometimes without thinking about it. And so therefore, drugs of abuse stimulate the same circuit, and we learn to abuse drugs in the same way. So it's a really powerful thing to understand the impact, the powerfulness of this, because that is a thing that can get people potentially dealing with addiction scenarios. Now again, we're not trying to stigmatize. We want to make sure that people understand what they're getting to. And I think our job as clinicians is to, number one, do no harm, and the Hippocratic oath that a lot of us have taken. But we want to make sure that our patients are educated. So I want to ask Dr. Hong this. How do you educate patients on some of the potential severity of prescription opioids? How do you approach somebody and say, hey, this is how the medicine works, and this is what may happen in the body?
When I make a decision to offer an opioid to a patient, I think it's very important to be transparent with the patient about the risks, the benefits. I think too often opioids are started and the risks aren't fully discussed. And patients that start on opioids for postoperative pain or for an injury, oftentimes they end up staying on opioids a lot longer than they should have been, and pretty soon they become dependent, intolerant, and potentially addicted. And so a patient that is being considered for this therapy really needs to understand the gravity of the risks. There are not just risks, though. There are benefits. And I think it's easy to look at this very one-sided and think that these opioids are inherently evil. Really, they still serve an important role in our armamentarium for treating acute and chronic pain. What I like to discuss with patients is, look, if I'm going to start an opioid for the treatment of whatever condition, I like to put a time frame to it. And I also like to discuss alternative options in terms of how can we identify the source of your pain, what are other options that exist to try to treat the pain. Because, look, if we can avoid starting an opioid at all, if it's not necessary clinically, I think our society needs to learn that we need to explore other options first before opening that door to opioid treatment.
Excellent. Thank you, Dr. Ong. I want to pose the next question to Dr. Johnson. And even though she's not necessarily a prescriber of this, she deals a lot as a psychiatrist. You see a lot of mental health challenges that people go through, and a lot of times we can say, well, this person's got addiction, this person is dealing with, maybe they have a mental health condition. But how do you really kind of balance it out? Because certainly people may have legitimate pain, but they may also have other mental health conditions they're dealing with. But when you see kind of patients in your practice that may, as you review their medications, you might see an opioid, does that change how you approach in dealing with their mental health?
It depends is sort of the short version of that answer. It may certainly affect, if somebody's coming to me and they have chronic pain issues and also depression, I may look at a medication that, some of the antidepressants we use are also, there's very good data on assisting the treatment of pain, right? And so, I may choose one of those preferentially. We often will talk about, what are the effects of the chronic pain medications in any form, whether they're opiates or not. What are the effects potentially on your mood? How are these affecting your life? I have a lot of patients come in and they're like, oh, I'm so tired all the time, I'm so sluggish, and part of that may well be depression. Part of that may also be the fact that somebody's very sedated, and so we try to kind of balance out what's coming from where. The other thing I think the perspective I kind of take on it is, I really think all pain is legitimate pain, right? Whether that is pain because your bone is broken or pain because your body is telling you something, right? And certainly, I see a lot of trauma patients. Trauma is, emotional and psychological trauma is sort of one of my specialties, and so we have a lot of good data. I think as providers and as therapists and everything else, we've known for some time that the body can kind of hold on to things in certain ways. We're now starting to see data showing that the physiology of that is very real and very concrete. And so, whether, like I said, whether it's that, there's a malalignment of something and some nerve entrapment and this, that, and the other, or if it's that there's some experience or some product of something that your body is trying to communicate to you, it's going to produce pain, it's going to feel like pain, we have to consider that experience regardless. And so the treatment of it may be different, but maybe not. I think the best approach is to kind of come at it from a holistic approach, right? So treating the actual pain symptoms, treating what's going on in their life, treating what is driving, maybe some of the other factors. I think you have to really get into all of that.
Well, thank you. And again, I think one of the things that we're talking about now is that this is it's a complex issue, and we want to make sure that our patients that we interact with have all the resources necessary to be successful with their health, and even when they have legitimate pain as well too. Dr. Weiner, you're involved in a lot of the education component, and certainly education physicians. And that's one of the things I would say, probably, Dr. Hong's an expert in this, but maybe Dr. Johnson and I, or certainly from my own perspective, I didn't get a lot of training in medical school nor in residency on how to prescribe necessarily opiates. It's different when, as an internist, I treat diabetes, or I treat hypertension, or I treat high cholesterol. It's a different kind of game, and I think a lot of physicians, certainly in primary care, may be ill-prepared to kind of tackle this epidemic, certainly when you have people that are living longer with more complex medical conditions and maybe a lot of surgical history. How do you go about just kind of initiating some strategies for physicians or other providers, just to be comfortable to have this kind of discussion about opioids?
Yeah, absolutely. And I should mention, so I'm a psychologist, so I'm a PhD rather than an MD, and I think that my physician colleagues have been very gracious in terms of working with me as a partner, based on my areas of expertise and the experiences that I've had. I think a big part of this has to do with willingness, and I've also found that many physicians are open to saying, hey, I know this is a problem, and I know I haven't been trained about it, and I would very much like to address it. And particularly when you work with them from a very evidence-based perspective, and you bring in the journal articles, and you look at the data, and you talk about the CDC and what Centers for Disease Control and the American Medical Association, and you use that as part of the training, I think it's a lot easier to help educate folks who are willing to adapt their practices, because everybody's concerned. I think if I had to pick a couple points where folks are getting hung up the most, I think a lot of it actually has more to do with the dynamic between the patients and the providers than just having the information. So to give you an example, say a physician's been working with a patient and they've been increasing the dose of Norco or hydrocodone or Vicodin or whatever it is for slowly over a number of years, because the patient's been developing a tolerance and they've just been upping it because maybe that's what they were taught, and maybe at some point they added something else on. And so now they're in a situation where they've created a medical problem, where someone's at a dose that's much too high, or maybe there was another physician who did that and then retired and then dumped that person onto their panel, right? Just they're being passed a case that's very challenging. So then you have to talk to the patient and not only say, if it was you, like, hey, I got you into this mess, which is a very face-threatening thing to do, and it's hard. I think a lot of people view physicians as not necessarily like people too, in some ways, like they know everything, right? And it's like you just do what they say, and it's a very humanizing thing to say, I made a mistake. But then even beyond that, the idea of talking about a taper. Now, how do we get this under control? How do we get you to a lower dose or off? It feels very threatening because people have a lot of questions, like what if my pain gets worse? What happens next? What other interventions are there? And that brings up a lot of anxiety, and one of the things that we know is that depression, anxiety, like Dr. Johnson mentioned, that actually enhances your feeling of pain. So there's a lot of elements to this that interlock, but just demystifying the process for physicians and then also for patients and educating them about what should you know about this. You can talk to your physician about this. It's okay. And the last thing I'll mention is from the physician side about how if someone does develop an addiction, and they mention like, hey, I've been hopping around to lots of doctors and getting pills, or I haven't been taking this as prescribed, to not just kick them out. And we see this sometimes, that physicians will actually take it almost personally, like that they've been lied to, and that someone's been going behind their back, and really letting people know, you know, this is, if someone has strep throat, they have a sore throat. If someone has an addiction, they lie to you and they get medication from multiple places, or they buy off the street. It's not personal, and you've just uncovered a treatable health condition, right? There are treatments for this. Kicking someone out or cutting them off immediately exacerbates the issue.
And a lot of times when people, you kick them out and they may cut off supply, if they don't find it on the street, they will certainly end up in the emergency room and adding to some of the dollars in potential withdrawal situation. Mila, what are some of the initiatives that are going on right now in DuPage County to help work together with the hospital systems and the physicians in the area? What are some of the things that are going on out there? You know, say if there's somebody listening to the show or watching us live on Facebook now, and they may have a relative or a cousin or a child that's dealing with this. How do we best get them the resources that they need to hopefully help educate them and hopefully help to lead to solutions to this problem?
There's several different things going on in the county and actually statewide, where people can find resources on how to find help. The state of Illinois recently launched a helpline to address 24/7, so people can call in and ask questions and try and get to some resources, either for Narcan or for treatment. That hotline is suitable for all substances, not just opioids, and also the people at the other end are trained to talk to folks that might be dealing with drug use themselves, or it might be a loved one or a friend. Additionally, the DuPage County Health Department and the Narcan program with our partners is working to get more Narcan into the hands of people that really need it. So fortunately, over the past 4 years, or almost 4 years, we've had more than 480 successful reversals using Narcan by law enforcement, which is a lot. It's important to mention that the DuPage Narcan program is mainly DuPage, but not only DuPage. We have lots of other communities outside of the county that participate. So what we're doing now is we're trying to make sure that people in the community that need Narcan, that know there's a drug issue in their home or have opioids in their home, that they have Narcan at the ready. And the third thing that I focus on is the importance of safe disposal of medication. Opioids are prescribed, they're prescribed for very important healthcare issues, but when they're not needed anymore, it's time to dispose of them safely. And in 2009, the health department started a program called RxBox. And at that time, it was really an environmental problem. We wanted to make sure people didn't flush it down the toilet. Today, more than 46 tons of medication has been collected through that program alone, and that number just keeps going up. So what we wanted to do is get opioids off the street, out of the medicine cabinet, and dispose of safely, whether you do it through the RxBox program or Walgreens or some other disposal method.
Excellent, thank you. You know, it's interesting about how we're talking about some of the resources out there. Again, we have resources when we're trying to identify patients that are at risk for abuse. But a lot of times we forget about the back end, the millions of people that have had these medicines and may want to legitimately get off these medicines. Dr. Weiner, how do we bridge that gap, and how do we create access and equity in our communities, that the communities that may not have some of the resources to help people successfully get off some of these medicines?
It's a really important question. So I think the first question is, are they chemically dependent, or do they have an addiction? And the biggest difference I put there is anyone who's taking opioids for a long period of time at a reasonably high dose, their body will develop a tolerance, and if they discontinued immediately, they'd have withdrawal. But that doesn't necessarily mean that they can't stop if they want to, right? It's much less strong of a withdrawal syndrome, but if anyone's, say, gotten off of caffeine, which is something that I did about a year ago, like, you'll feel it, you know, like you'll go through something that's negative. Your cravings won't be as strong, it won't be nearly as intense, but you can get through it. And similarly, I've actually worked hand in hand with primary care physicians who have stepped somebody down over time who's wanted to taper off of hydrocodone, Abnorco, Vicodin are the brand names for that, but just slowly, and helping facilitate a taper and helping work with the patient so that they're being monitored essentially, and making sure that they're staying with the program. So those folks, the easiest way to do it is just to empower physicians to engage in a taper, know how to talk about it, give support, and connect with behavioral health. For those who've developed more of an addiction, which is a compulsive pattern of use where their use is really out of control, oftentimes these folks are also medicating for mental or behavioral health reasons, not just their physical pain, that they're using it to numb their feelings and their physical pain. That gets a lot more complicated, and we have medications that can help. I think methadone's been mentioned as one. Suboxone is another one that we use a lot. That's the brand name. Buprenorphine is the generic. But these drugs actually greatly enhance the chances that someone will be able to get off and sober from these medications. Actually, for those trying to get off of those, heroin as well, for example, if someone goes to the street, heroin's less expensive, so if someone makes it to the street, that's oftentimes why they bridge over there. There's actually been multiple studies that have found there's up to a 90% relapse rate in the first year for people trying to get off of opioids if they've developed an addiction. So there's medications, there's help, but really getting someone engaged in the program, it's huge, and absolutely there's access issues too.
You're talking about medication-assisted treatment, and a lot of systems are now trying to get these comprehensive programs set in place to certainly hopefully help those that are struggling to be successful in their efforts to get off of these powerful medicines. I know at our facility where we're at Edward Elmhurst Healthcare, we certainly have developed a clinic that can help out, but a lot of the university hospitals have developed clinics that can help out and really given a nice multidisciplinary approach. And it's interesting about some of the studies that you mentioned. I want to kind of point out a pilot study that was done in the city of Chicago, where they had an expansion of outpatient methadone treatment services to minority residents. And we're talking about, again, some of the times when we talk about health issues, we look at some of the disparities that are there, and certainly saying the haves and the have-nots. And certainly when we see some of the socioeconomic disparities, it can be even much more of a challenge to have people become successful. So I want to highlight a case study that looked at individuals in Chicago and minority residents that underwent through an expansion of services through a methadone treatment clinic. And the interesting thing is that between time 0 and time 6 months at follow-up, those that were successfully integrated into a multidisciplinary approach with behavioral health on top of that had an increase in the percentage of clients being employed. So we're talking about having legitimate jobs for people that may have not had access to gainful employment. We see an increase in average income and wages, so to be able to help to support their families and loved ones. We actually see a decrease in income and decrease in spending from spending money on illegal sources and illegal services. And that includes spending money on illegal drugs. And then we saw the people that were engaged in these programs were successful. As you kind of mentioned, the relapse rate is quite high if we don't have those resources there. So this kind of highlights that don't say it takes a village, and it really does when you think about healthcare in general, and certainly on this topic. I want to ask the next question to Dr. Hong. How do we train our first responders? The EMS, law enforcement, and I want to piggyback on that is because some of the data is really, really interesting, because as we're facing this epidemic, I've got some data here. In the year 2015, there were 9,272 uses of Narcan, but prior to that, 2 years prior, there were 6,992. So we had more than a 30% jump in the use of reversal medication in just a 2-year time frame. So how do we best educate our first responders that are out there on this topic?
That's a great question. I think one of the benefits, one of the silver linings here of this whole opioid epidemic has just been, it's in the public now. And my patients are more aware of the risks. I think as providers, we're more aware of the potential downsides as well. And so like I mentioned earlier, there's the pendulum is swinging the other way. So I think we have a captivated audience at this point, physicians, first responders, and patients alike. When a first responder arrives at a scene where somebody is showing signs of opioid overdose, such as respiratory depression, unresponsiveness, I think that opioid overdose has to be one of the first things they consider. And I feel that all first responders, if not already, should be have immediate access to Narcan. And just for those of you who don't know what Narcan is, it's basically a drug that blocks the opioid effects on the receptors in the brain and in the central nervous system. So having Narcan present and administering it appropriately in a timely way for somebody who is overdosed can be life-saving. And so it's a simple education about identifying the right patient and having the right tools necessary when they respond to these type of situations.
It's interesting how I like that how you say, we put it right in the face, and I think it's certainly in line of like, we create a lot of urgency when it comes to cardiovascular disease, when it comes to diabetes, and knowing that the complications of those conditions are serious. The complication in this case can potentially be death. And so we put it in the face, and I think as a society, and certainly as clinicians, we try to rise to the occasion. And I think there's still a lot of good people out there, more so than bad people in the world we live in, that want to do good things and help out. And so it's interesting that the Narcan law was passed in Illinois in 2010 that made it legal for well, certainly as far as in the public sphere, made it legal for non-medical persons to administer the drug to help reverse the effects. And then in 2012, another act was passed in Illinois that considered a Good Samaritan law within specified limitations that you can't be charged with a felony if you're trying to help somebody out who was legally or illegally in possession of such an opioid or heroin substance. So again, it takes a village to do this. So again, I think we know that the education is out there. Just how do we preach that to the masses? Because again, we still come down to a comfort level, and again, we put it right in our faces as first-line responders. But how do we even create more of that urgency? And that's the biggest thing. So I want to ask the next question to Dr. Johnson. What is the role? What is our role as humans? Or better yet, what's the role of at the local level or at the state level or at even the federal level to provide these resources when we're talking about people's lives?
I mean, I think, we all have an obligation to take care of each other as humans, right? I think that, like you said, we think of this as something other, right? We talk about, we gotta get your blood sugar down and we're gonna get you on a blood pressure medicine, and everybody's totally fine with that, but to deal with your mental health, and particularly to deal with addiction issues, everybody's sort of like, oh, not in my house. We're gonna send you for to someone for that. And I think, like you were saying, one of the silver linings of this is, in some ways, it's getting us all to kind of come together, and we've all got to kind of come out of our silos, right? Like, we're all, medicine for a long time has been this very split system of, mental health over here, physical health over here, specialty medicine here, primary care here. Like, we're all just, and maybe we talk to each other and maybe we don't, and some groups are better at that than others. The fact of the matter is, we all kind of have to get together on this one, and we all have to kind of take care of the whole patient. One of those things is really talking more about addiction, and primary care doctors are so on the front line of this. I mean, by the time they get to us, there's interventions that have been tried, there are things going on, there's usually some stigma that's been attached somewhere, not always, but frequently, versus, primary care providers, I think, are in this unique situation where they have this relationship to the patient. If they can make it just sort of one other thing that they talk about, like, what are the substance issues going on here? Just a simple screening, or even just getting into the mental health piece, and looking for symptoms of depression and anxiety when someone's coming in with for a pain visit, or kind of all of these things, and they really have a unique place to kind of intervene. I also think there's, part of what I do is I spend some time embedded in the primary care office at Loyola, and so, or one of the primary care offices, and so I hear a lot from the providers that, like, a lot of them are feeling very responsible because we've come from this culture, and like you said, when we graduated medical school, the opiate prescriptions were a third of what they are, right? And so, we've come from this culture of, zero pain is the fifth vital sign, we can't tolerate any pain, they have to have a zero, like, really pushing, you have to treat to nothing, and really not giving people the resources to say, a little pain might actually be a signal that you need to do something different. You need to pay attention and listen to your body, not push through your recovery too fast, all of these sorts of things. So they've really had a lot of, you have really had a lot of pressure on them to kind of treat pain aggressively, and now all of a sudden it's this reversal of, oh my gosh, everybody stop, what we've been training you to do for however many years, you have to do the total opposite of that. And so I think that can feel very overwhelming, and like, well, now what do I do? And so I think getting all of us to kind of have a conversation about, okay, well, now what do we do, and how do we think about this, and how do we intervene? I think that is going to be a tremendous gift that all of us can bring to the practice of medicine.
Excellent. I know one of the challenges that I go through on quite an often basis as a primary care physician is how do we get people to buy into those resources, because I certainly have acknowledged my limitations as a physician. I'm great at treating diabetes, I'm great at treating blood pressure, I'm great at other things, but I'm not so great at treating chronic pain, and I'm not so great at dealing with some of the mental health things. I just never got that kind of training, and I think a lot of my primary care brethren out there are going through the same challenges. So I think when we talk about linking up and having these relationships, that's so huge. But the biggest part from my end is, how do you sell that? Aaron, what are some of the other kind of strategies that you might advise clinicians out there to help better pass this message on to their patients, to say, hey, we want to link you up with these kind of services? How do we best kind of bridge that divide?
Well, I think a big part of it is this idea of normalizing team-based care, and also adjusting the way we talk about chemical dependency, and maybe say chemical dependency instead of addiction. So there's a whole cohort of folks right now who are misusing their pain medication, but would not identify as having an addiction. In fact, they'd be very offended because that's oftentimes a stigmatized term. And in some ways actually wouldn't even fit in a lot of the programming that I provide, because these are people who are buying off the street. who are actively doing things that folks who are getting legitimate medications from physicians, perhaps more than one, but they wouldn't identify. And so really being able to have a conversation, a good relationship with a pain clinic, with a PCP office, so that they can talk someone through the process of going over there and say, this does not say anything bad about you. You're using whatever strategies you can to survive, to work with your pain. You're trying your best to get by. This is not a bad thing. This is just the next step in your treatment. And having it be part of a solution where it's not that we're just abandoning you to your pain, but we've developed this chemical dependency we need to treat, and we also have to treat the pain.
Excellent. Mila, you know, from a preventive health standpoint, one of the challenges when we try to integrate physician practices for our patients and knowing that other partners out there like health departments, how do we do that? How do you guys kind of get your message out there to people on a day-to-day to know that primary prevention is there, that health department's there? A lot of people, I feel like when I see people come into my practice, a lot of times those they're not aware of those kind of resources that are there. Your public health department is there, and we want people to use and engage that. But how do you develop that kind of engagement?
I think that we rely on our partnerships with our healthcare systems and also our social services agencies. Many people who come through the doors of the health department are coming because they're coming for services. So our struggle really is, DuPage County has 1 million people. How do we reach 1 million people, right? That's hard. So we engage different partners to do that. We work with our school systems, our regional office of education. We work through our hospitals and the DuPage Medical Society to reach people on a greater level. And then just recently we're going to partner with the state of Illinois to do more about this helpline, which is a free resource. So you'll see these ads for the helpline, and we hope people engage and get into treatment and find out more about what they can do if they feel they have a struggle.
That's excellent that you mentioned about some of these resources are free of charge, because sometimes that's a big barrier to get people to go in to seek services. I know when I think about patients that may come into my practice and I say, hey, you know what, we want to engage, and this may not be related to opioids, but we want to engage in behavioral health. And one of the common statements in response is that, well, it's going to require more time from my end and more money. And that's a barrier right there. And even if when you try to explain to people that actually, you know, for based on their insurance, yeah, it might be actually very cost effective, but certainly to know that those resources are out there, that maybe it's a public aid person or a Medicare person, and they may not have those kind of benefits in their plan, and then this is a great way to engage. But I always tell people, you can have a great program, but if nobody knows that you exist, then what's the point? And so we want to make sure that people know that these programs are out there. I urge people to contact their local health department. That's a great way to start. I urge people that don't have a physician, get a primary care physician. That's step one. Because when things go bad, it's going to be your primary care physician who's going to get the first call, who will be there for you when you need it in that time, in those dire times. So that's really, really important. I want to change the topic a little bit, but before I do that, I want to read a quick statement. I want to thank my sponsor. We're not done yet, everybody. We still got a little bit more time, but I want to just thank my gold-level sponsor, Gateway Spine and Pain Physicians. Gateway Spine and Pain Physicians was founded in 2007 with the mission of providing exceptional care to those who suffer from acute and chronic pain. The experienced and compassionate team of specialists at Gateway go above and beyond to decrease pain and restore quality of life by providing cutting-edge medical treatments. At Gateway Spine and Pain Physicians, a customized treatment plan is created for every patient, utilizing a wide array of treatment options, including interventional and regenerative treatments. With offices conveniently located in Bolingbrook, Hinsdale, and Downers Grove, a pain-free life is right around the corner. Visit the website at www.gatewaypain.com or call today at 630-226-1130. Again, that's 630-226-1130 to set up a consultation. Don't live in chronic, uncontrolled pain. Visit Gateway Spine and Pain Physicians to find out how you can minimize pain and maximize life. And again, I want to thank Gateway on helping us out, and Gateway Spine and Pain Physicians for helping us out today. I want to, in the few moments that we have left, I want to kind of bring this home. We've had some good discussion, and again, this is a broad topic, but we've had some good insight at a broad level, and even a little bit of a granular level too, because we want to know that to people, we want to tell them that there are options out there to empower them in their lives and their health. So what I kind of call this, when we kind of get ready to summarize up, we call this the assessment and plan. And again, going back to at the beginning of the show, we talked about the chief complaint. So in medical care, we talk about the assessment and plan. And that kind of just kind of brings home the problem when you're seeing somebody and you kind of come up with a game plan, a strategy to help them with their issue of the day. So I want to start out with Mila. And I'm going to kind of say, what are kind of your couple takeaways on this issue of the opioid epidemic?
I'd start by just reminding everyone that if you have medicine in your cabinet, you need to dispose of it properly. And there's lots of ways to do that. But if you're in DuPage County, look up the RX Box program, you'll find places where you can go into a police department and safely dispose of your medication. Two, I'd like to remind people that Narcan is available in pharmacies without a prescription. There's a statewide standing order that allows people to purchase naloxone at the pharmacy, and many times it's covered by insurance or Medicaid. And three, if you don't have insurance and if you are looking for health care and maybe some benefiting, look at your health department's options for getting insured, because they can help you with that.
Excellent, thank you, Mila. Dr. Weiner, go ahead and give us maybe just a couple take-home points.
Yeah, so the first one I'd say is for patients, know what you're getting into. Ask questions. If someone's not telling you about risks and benefits, find out. Have that conversation with your physician when you start. The National Safety Council released a statistic as part of their campaign against this as well, that 66% of people on opioids don't even know that they're on opioids. It's a very high percentage. And so it's just something where, as healthcare professionals, we need to be talking about it, but from the other side, ask. It's important. And the second is, and this is following in the same vein, talk about it. I cannot overstate how much of an issue stigma is with this right now. Every time you talk to a parent who's heartbroken because they walked in to find their kid home from college dead on the floor, they never knew that this was going on. And we these days are talking more about depression than ever before, about suicide, about anxiety, about panic attacks, about all sorts of chronic health conditions, but we don't talk about addiction. And this is something you don't start at overdose. It grows, and it grows over time. It progresses. And if this is something that we could talk about with parents, with healthcare professionals, physicians, everybody, if we could get this, if we could speak about this more and not make it such a taboo, I feel honestly we would save lives that way alone.
Excellent. Dr. Johnson, final thoughts?
I actually really want to piggyback onto that. I think, the more we can destigmatize all of this, the better off we are. And certainly for both patients and for providers, specialists are here for a reason. Don't be afraid to use us. Don't be scared of us. We're okay. We're not psychic. We're not reading your mind, and we're not judging you. Come on down. We can help.
Excellent, thank you. And Dr. Hahn, final thoughts on this topic?
Well, it's a very important topic, and I appreciate the time that you've put into putting this together. It's a very important public health policy issue. As a pain specialist, I'm very passionate about the treatment of pain. And for me, this silent epidemic of chronic pain is really the root of this opioid epidemic. And I think education is key. Working collaboratively with other providers is key. Patients understanding the risks and the benefits. It requires a balanced approach on all ends. And I believe that prevention is important. If you are on opioids for more than a few months, regular usage, talk to your provider about what the game plan is. Do I need to see a pain specialist at this point? I really do recommend that if a patient is on regular doses of pain medications, opioid medications for more than 1 or 2 months, it's time to talk to a specialist. Find yourself a good pain management specialist to really review the risks, your other options. There are other options, and there are specialists that can provide you care. And don't let the stigma interfere with you getting the care that you really need.
Excellent, thank you. And my kind of last words, I'll say this. To get from point A to point B in your healthcare plan and your healthcare destiny may be overwhelming at times. It may be hard. With any kind of medical condition that we're dealing with, whether it's diabetes or hypertension or even opioids, there is always a solution out there. Don't be afraid to talk about it openly with your healthcare team. But remember, you have to have a healthcare team in the first place to be able to address this issue. So what I want to do, of course, is thank my guests today. We got Dr. John Hahn, founder and president of Gateway Spine and Pain Physicians. We have Dr. Kate Johnson, assistant professor at Loyola University Medical Center. We have Dr. Aaron Weiner, director of addiction services at Linden Oaks. And my last guest, Mila Tsagalis, director of community initiatives at DuPage County Health Department. Thanks again to my gold level sponsor, Gateway Spine and Pain Physicians. Next week, we're going to be talking about designing the next generation corporate wellness plan. Of course, my name is Dr. G. Follow me on Instagram, Facebook, and Twitter at To Your Health, Dr. G. Check me out on my website at www.drmarkgomez.com. See you guys next week, and peace out. All right, thanks, guys. All right.
Good job.
Great.